I started down this interesting road with the readmissions around 2010, and in retrospect, my perspective at the time was that heart failure readmissions is a problem that belongs to cardiologists, and we need interventions that relate to heart failure and cardiology. In retrospect now, having been in this field for the last several years, I'm starting to recognize more and more that siloed interventions specifically aimed at cardiac kind of things may not be the solution. So our big excitement over telehealth monitoring back in 2010, excitement about heart failure specific education, etc. I think that has waned somewhat. So the talk that I'm giving you now is something I've been thinking about more recently, and I think that my point of view on it has evolved. 50% of my time I am a cardiologist in the section of heart failure, and 50% of my time I work as the director of the Center for Connected Care, which is a center that's been around for about 9 months that has oversight for various post-acute care operations like home care, hospice, skilled nursing facilities. And that half of my life really doesn't have so much to do with cardiology. So I'm giving you a perspective from both sides. So first of all, we've all heard about this. Readmissions are expensive. A 2013 report by MedPAC, the group that advises CMS, detailed that they estimate that CMS spends about $26 billion per year on readmissions, and they estimate that $17 billion of which is potentially preventable. Over the last few years, CMS has taken 2 steps at addressing this costly readmissions. The first one is public reporting, and the second one are fines. The first thing I'll describe to you in a minute here is public reporting. So you've all seen or heard about this website, the Medicare.gov Hospital Compare website, where you can type in your hospital's name and then compare that to another 1 or 2 other hospitals. And once you type in Cleveland Clinic, you see something along these lines. If you look at the heart failure section, there's also data about patients who are hospitalized for pneumonia and patients who are hospitalized for heart attacks. And you can see the blue line shows that that the average readmission rate in the country is about 24%. In this time period, Cleveland Clinic had a 28% readmission rate with a range from about 25.5 to 30, and that's based on about 1,094 patients. Interestingly, there's data now showing that, in fact, customers, patients, don't always use this data to make decisions about hospitals. So while this data is out there, it's not exactly clear that this has been a cause of readmission rates going down. All right, so money talks, right? Section 3025 of the Affordable Care Act established the Hospital Readmissions Reduction Program. And that program basically requires Medicare to reduce payments to hospitals with excess readmissions effective for discharges beginning last year in 2012. And how did Medicare come about these fines? So a few things that are important to note. The HRRP penalty is calculated via a risk-adjusted formula that compares a blend of readmission rates at this point for 3 conditions: heart failure, AMI, and pneumonia, and compares that blend of readmission rates to averages across the country. Secondly, it's important to realize that the penalty is a percent of total CMS payment to the hospital. So it's not that the hospital is not going to get paid just for the heart failure readmissions or just for the pneumonia readmissions. They're going to get penalized on a percent of the entire Medicare payment, which can turn out to be a lot of money. Last year, that penalty was capped at 1%. And just to give you an idea, Cleveland Clinic was fined 0.75%, which ended up being about $2 million. This year, the penalty has grown by 1% to 2% or less, and it's still based on a blend of these 3 diagnoses. And next year, fiscal year 2015, interestingly, the penalty is going up to a cap of 3%, and the readmission diagnoses that this is going to be derived from is increasing. So it's not just going to be heart failure, AMI, and pneumonia. Now there's going to be readmissions for COPD that are going to be interrogated, as well as orthopedic. The hips and the knee replacements are coming into the new formula. One more thing I want to mention before I go to the next slide. So this year, 2/3 of American hospitals were penalized, about 2,225 hospitals. The penalties that hospitals faced ranged anywhere from 0.1% to 2% of their entire CMS payments. But only 18 hospitals in the country were penalized the full 2%. So it's not just 1, 2, or 3%, it's a range that's capped at a certain number, and it's increasing every year. This isn't coming out very well, but I'm going to explain it. So I put this data together looking at how penalties from 2013 and penalties from 2014 affect hospitals here in Ohio and within the Cleveland Clinic system. So if you look at the line of identity, this line of identity shows what the penalties were in 2013. Here you have the main campus, okay? Last year we were penalized in the main campus 0.75% of total CMS reimbursement. This year we did something, I'm not exactly sure what we did, but the penalties have dropped to about 0.3%. And you can see how other hospitals in our system and some of our competitors compare. So for example, up here you have Marymount, which didn't do too hot last year and has gotten worse this year. Interestingly, UH is down here. Their penalty last year was incredibly low, and they've gotten even better. So this puts things somewhat in perspective. Now, looking at, I think that I'm one of the 2 or 3 people around the country who actually read this MedPAC report, but MedPAC identified a few different problems with HRRP. And I think it's worth pointing it out because this, what MedPAC advises usually CMS adopts within a few years. So here's what may be coming down the road. So issue number 1 that they identified is hospitals with a small number of cases may receive a penalty due to random variation. And if you think about it, that makes sense. If you have a hospital that only takes care of 10 heart failure patients per year, and for whatever random reason, 1 year 12 patients show up, that could impact the way the penalty is derived, and that's not so much due to quality or interventions they did or didn't take, it's just, bad luck. So some of the proposed solutions to that are, that MedPAC proposes, number 1, replacing all the diagnosis-specific penalties with all-condition readmission penalties. So this is coming down the pipe. Using 3 years of data instead of 1 year of data, which simply increases the N. And finally, allowing hospitals to aggregate performance within a system. And I think that this is really fascinating. This is going to allow hospitals to voluntarily choose partners out there and say, Fairview and Hillcrest, we're not just going to look at you specifically, but we're going to look at your composite readmissions for both hospitals. And in fact, what this is probably going to do strategically is it's going to force hospitals and hospital systems to collaboratively work together to take care of populations of patients. So I think that that's interesting and kind of smart. Issue number 2, which is near and dear to my heart, is that some hospitals may be more likely to receive penalties if they have low mortality or if they have high admission rates of low severity patients. And I'm going to explain more of that. So in 2010, we published this letter in the New England Journal of Medicine along with Dr. Starling and Dr. Blackstone. And what we did is we compared the risk-adjusted 30-day mortality rates for heart failure patients to risk-adjusted 30-day readmission rates. And what we did here is we used the publicly available hospital compare database that anybody can just download on the web. This looked at the performance of 3,857 hospitals all across the country. And what we saw is that amongst heart failure patients, there seems to be an inverse relationship between mortality and readmissions. So hospitals that seem to have higher readmission rates seem to have lower mortality rates. So this was our argument at the time, and it's kind of neat to see this reference now in MedPAC. But some of the solutions they're offering there, again, all-condition readmission metric, because other authors have analyzed this relationship for pneumonia and heart attacks, and they don't see it. It's a flat line. So what MedPAC is suggesting is make it all-condition, so the heart failure thing that you're seeing there will wash out. So that's how they're going to respond to issue number 2. Now, issue number 3, hospitals that take care of lower income patients, lower socioeconomic patients, have higher readmission rates. Many authors have shown this in the literature. This is nothing new. So therefore, these hospitals, imagine this, you take care of lower socioeconomic patients and you're more likely to get a penalty. That doesn't seem fair. So the proposed solution there is that instead of comparing each hospital to the entire country, hospitals are going to be compared to their peers who take care of patients within the same socioeconomic status group. The risk adjustment that goes into these formulas is based on billing data, and that billing data very poorly reflects socioeconomic status, so comparing it to peers may be an interesting solution. The takeaway message for me is that CMS readmission penalties are evolving. In the next few years, we're going to see the diagnoses expand at first, but then I think that what we're going to see is everything is going to contract. All these disease-specific silos are going to go away, and it's going to be an all-condition readmission metric, which is interesting because if you're trying to come up with solutions to address the readmissions problem, you shouldn't think about it the way I did in 2010, which is, what is a heart failure specific intervention? This is really not about a diagnosis any longer. So money talks, and truly innovation is happening. Here's data that was published by CMS just a few months ago. And what they're showing here is that ever since the penalties and the public reporting has started, over here on this side, you can see that the graphs for readmissions and admissions are separating. So hospitals all across the country are figuring out ways to reduce readmissions. This is really happening. And what's further interesting is that it may be that these interventions that are being rolled out to reduce readmissions, care coordination, etc., is also reducing overall utilization, and that's why you're seeing lower admissions. So they're definitely saving money. Now this is a map of the United States that shows, using colors, the change in readmission rates over between 2011 and 2012. The little lines describe Medicare hospital referral regions. Dark blue areas show regions where readmissions dropped by a lot. Light blue show areas where readmission rates dropped some, but not so much. And then in red and orange are areas where readmissions got worse. And you can see that really across the entire country, there's things happening. Readmission rates everywhere seem to be going down now, at different degrees based on the region, but it's clearly happening. All right, so the organizers invited me to address readmissions, what works. Well, I'm not ready to talk about that just yet. I want to give you a little bit more background. If you look at why do patients come back to the hospital, you see that for any condition, the most common reason that patients get readmitted has nothing to do with the index diagnosis. So a majority of patients hospitalized for heart failure come back for conditions other than heart failure. This applies to COPD, pneumonia, GI problems, etc. Again, coming up with an intervention that's specific to the index diagnosis may not be the right way to go. I thought that this was a great quote. Interventions targeted at specific diseases responsible for only a fraction of all 30-day readmissions may be less efficacious. Mark Williams wrote this editorial that was published a few months ago in JAMA, and I think that the title says it all. A requirement to reduce readmissions, take care of the patient, not just the disease. I don't know how many people saw this perspective piece. It's beautifully written by Harlan Krumholtz from Yale, and I'm going to read you a few sentences from his perspective piece. During hospitalization, Patients are commonly deprived of sleep, experience disruption of normal circadian rhythms, are nourished poorly, have pain and discomfort, confront a baffling array of mentally challenging situations, receive medications that can alter cognition and physical function, and become deconditioned by bed rest or inactivity. Each of these perturbations can adversely affect health and contribute to substantial impairments during the early recovery period, an inability to fend off disease, and susceptibility to mental error. Again, it's not about the disease, it's about the patient. I want to show you some data that we've been collecting, and we're writing this up for the American College of Cardiology. We've asked over the last year the care advocates on the main campus who see the heart failure patients to do the mini-cog test for heart failure patients. And the mini-cog is a test where you say 3 words, you ask the person to repeat them, you tell them to draw a clock. In this case, we asked everybody to do 15 minutes before the hour, before 10, and then repeat the 3 words again. So what I'm going to show you now is I'm going to show you clocks that heart failure patients on the main campus drew. Okay, so this is a beautiful clock. It has a little alarm bell on the top. Beautifully done. There's a circle. All the numbers are in the right place. This is the long arm. This is the short arm of the clock. This looks good. I would trust this patient to manage her own medications at home. I'm sure she's going to do very well. So let's keep going. Here's an 80-year-old woman who drew a clock. Looks pretty good. The arms of the clock are not exactly right. You know, one should be long, one should be short, and they're reversed. I'd still let her pass. Let's keep going. This 74-year-old man, not bad. The numbers are in the right place, even though, again, the arms of the clock are both the same length, which is not correct. Okay, maybe it's a problem with error, but not with cognition. Well, this person got the wrong time. So that's a problem. This person forgot the hour 11. Again, the circles are no longer much of a circle, but you can see that the time is wrong, the arms of the clock are off. This person couldn't decide what time it is. Okay? This is the kind of people that we know. We're giving them their discharge summary with their 8 medications, and we're sending them home and telling them good luck. This person clearly has problems, and if we didn't test them, it wouldn't have been clear what was going on, but you're getting a sense. As I go on, you're gonna laugh less and less because you start realizing the severity of the problem that we're dealing with here. So you get a sense of what's going on here. This person drew this is Pac-Man. Here the time is wrong, there's no numbers, the arms are wrong. This person decided the first clock was wrong and then drew it again incorrectly. This is like a digital clock, 10:45. This person tried to draw a clock and then came out like a Salvador Dali piece, and then they gave up. So we're still finalizing this data, but we had over 730 mini-cog tests. At the initial look at the data, about 35% of patients, we rated them as having high probability for cognitive impairment. And we also started looking at the data, and at first glance, clearly the patients with high probability for cognitive impairment had higher all-cause 30-day readmission rates back to our healthcare system. So again, my point is, it's not about the disease, it's about the patient. Coming up with interventions that are siloed and just specific to a disease may not be the way to go. This is a study that was published a few months ago in Circulation, Cardiovascular Quality and Outcomes. And these authors sent 599 different hospital surveys, asking them what type of strategies they employ to reduce readmissions. And here are the strategies that hospitals highlighted: partnering with community physicians, partnering with other local hospitals, having nurses reconcile medications, arranging follow-up appointments before discharge, arranging for discharge summary to be sent to the primary care doctors, assigning staff to follow up on pending test results after discharge. Bottom line is, hospitals that deployed more strategies seem to have modestly lower readmission rates. The takeaway point for me is that there's not going to be a magic bullet. And a lot of things probably work a little, and we probably need to do a lot of things in combination in order to move the needle downward. In orange are interventions that have some randomized clinical trial evidence behind them. So the discharge checklist, specifically something called Project Red out of Boston University, has a randomized clinical trial demonstrating its efficacy in improving outcomes. Partnerships with home care and SNFs, partnerships along the continuum, there's several randomized clinical trials there. Timely follow-up, no randomized clinical trials that I know of there. It seems to make sense. Is it 7 days? Is it 14 days? Is it 3 days? Everybody's still arguing about it, but it seems to make sense that if we see patients earlier, they'll do better. Meals on Wheels, again, socioeconomic status does play a role with readmission. Community church-based programs, no randomized trials, but there are articles out there that when communities take care of their elderly frail, they seem to do better. Education and coaching. Mary Naylor, Eric Coleman have published randomized clinical trials looking at how care coordination, coaching, and education in different models seem to improve readmission rates. Sharing records with primary care doctors after discharge. There's no randomized clinical trials. It's kind of like trialing a parachute jumping out of an airplane. No one's going to do that. It's the right thing to do, and it makes sense. Assigning nurses to manage medication plans. I think that a lot of these things are not rocket science, but you have to do them in combination, and you can't focus on just one intervention, because one intervention is probably not going to work. Finally, I want to wrap up by giving you an example of something that the Center for Connected Care has been doing. We have a program called SNF Connected Care. It's a service line in our Center for Connected Care, and what we've done is we've identified 9 high-value SNFs in Northeast Ohio, 2 of which are owned by Cleveland Clinic, the rest are not owned by Cleveland Clinic. And we have embedded Cleveland Clinic salaried physicians and nurse practitioners in these facilities to see patients who are discharged from the Cleveland Clinic health system who go over there. And what these practitioners do is they see the patients 5 out of 7 days out of the week. By the way, by law, in SNFs, patients only need to be seen once every 30 days by a physician. So really the intensity of seeing patients in our program is incredibly high compared to that. All of our practitioners document an epic, so we're turning on the light and the continuum. You can actually see notes of what happens in the SNFs. Our practitioners have joint quality committees with a partner SNF administration. They review outcomes, they review quality, and they try to improve all the time. We're going to be able to implement care paths when those come out, and we hold everybody accountable for readmissions and outcomes. Here's a map of the SNF Connected Care sites. On the east side, we have Montefiore and Menor Park. Closest to the main campus, we have Kindred. On the south, we have Villa St. Joseph. On the west, we have Bradley Bay, Wellington Place. McGregor just went online 3 weeks ago. All of these facilities are facilities that we chose because they're high-value facilities that Medicare has rated 4 or 5 stars, and where historically Cleveland Clinic patients have wanted to go. So these are, I'm showing you this picture just to give you the gut feeling that these are real people. These are our colleagues. You can page them through the paging system. You can email them. You can call them on their cell phones. These are Cleveland Clinic salaried folks who work in these facilities. And here's what we've seen. Historically, the readmission rates from these SNFs was 26.8%. Currently, SNFs that are not in our SNF Connected Care program have readmission rates that are close to 29%. And quarter by quarter, what we're seeing is readmission rates of Cleveland Clinic patients coming out of these SNFs dropping down. At this point, we're almost 9 to 10% lower than historical rates, which is something that we're extremely proud of. We've had a pilot with Anthem, one of the big payers, and they told us, we don't understand. Our spend on SNFs has gone down, length of stay in SNFs has gone down, readmissions have gone down. Well, this program is producing good outcomes and saving money. And this is just one example of how we operationalized the concept of creating partnerships across the continuum of care. Finally, a requirement to reduce readmissions, take care of the patient and not just the disease. Thank you very much.